Welcome to the Deep Dive. We're diving into a lecture today by Dr. Oscar Palazon, and it's all about bradyarrhythmias and pacemakers.
Sounds intriguing.
It is. And get this, we might uncover that some common practices, like which pacemaker to use, might not be as evidence-based as we think.
Oh, that's interesting. Dr. Palazon does like to challenge conventional thinking, doesn't he?
He does. So first up, bradyarrhythmias.
Mm-hmm.
We hear that and think like, dangerously slow heartbeat, right? But Dr. Palazon says focusing only on a low heart rate can be misleading.
Yeah, I see what you mean.
So help us out here. What's the real issue then?
Well, it's not just about how slow the heart's beating. It's about, is that slow rhythm causing problems? You know, like with blood pressure and circulation.
So it's like if the slow beats aren't getting enough blood to the important parts.
Exactly. And here's where it gets kind of crazy.
Okay.
Sometimes, like, trying to speed up the heart with drugs can backfire.
What?
Yeah, he tells this story about isoproterenol, a drug that's supposed to increase heart rate.
I've heard of that.
But it can actually trigger more serious arrhythmias for some people.
Whoa, so trying to fix the slow heart rate could make things worse.
It can. That's why getting the diagnosis right is super important.
Makes sense.
Dr. Palazon talks about, distinguishing between sick sinus syndrome, SSS,
Okay.
and heart block.
So what's the difference?
With SSS, the problem's in the sinus node, the heart's natural pacemaker.
Okay.
It's like the pacemaker itself isn't working right.
Yeah.
But with heart block, there's a disruption in the electrical pathways, like the wiring of the heart.
So SSS faulty pacemaker, heart block faulty wiring. Got it.
Yeah, good way to put it. And they can both be serious, but SSS is usually less immediately life-threatening, because the heart often restarts itself.
Oh, okay.
And he really emphasizes that you got to look at the patient's symptoms along with the type of arrhythmia they have.
You mean like just because a heart monitor shows a skipped beat or something, it doesn't automatically mean it's an emergency?
Exactly. But here's the thing. More and more bradyarrhythmias are being found during, routine monitoring, especially in folks with sleep apnea.
Oh, wow.
Makes you wonder, are we overtreating some of these?
Right. Just because we can see it doesn't mean we have to do something about it. So how do we decide when we need to intervene? Like, when's a pacemaker actually necessary?
Well, that's where it gets really interesting.
Okay, tell me more.
We got to talk about monoameral and bicameral pacemakers.
All right, lay it on me, Pacemaker Pro.
All right. So monoameral pacemakers, they have one lead in the ventricle, one of the heart's lower chambers.
Mm-hmm.
Bicameral have leads in both the atrium and ventricle, both upper and lower chambers.
I would think bicameral would be, the obvious choice,
Yeah.
right? More coverage, better results, that kind of thing.
Yeah, you'd think so, right?
Yeah.
Well, get this. Bicameral pacemakers are the most common type implanted worldwide,
Mm-hmm.
but there's no strong evidence that they're actually better than monocameral for most patients with heart block.
What? No way. Why are we using something so much when it might not even be the best option?
It really makes you think, doesn't it, about how these medical practices come about.
For sure. And it makes you realize how important it is to understand all this and ask questions.
Exactly.
Well, before we get into the philosophy of all of it,
Yeah.
let's talk more about different bradyarrhythmias, like 2.1 AV block.
That's a tricky one.
Yeah, what is that exactly?
Imagine this. Only every other signal from the atrium makes it to the ventricle. Really hard to tell if a pacemaker is even needed.
So it's not a simple yes or no to a pacemaker then?
Not at all. Dr. Palazon, he uses clues from the EKG, like how wide the QRS complex is. That shows the electrical activity of the ventricles
Okay.
and how the patient responds to things like carotid sinus massage.
Oh, right. I remember that.
Yeah, to figure out if the block is benign or dangerous.
So tell me about those diagnostic tests, the massage and the
Atropine.
yeah.
Right.
How do they work?
Well, with the carotid sinus massage, you're stimulating the vagus nerve in the neck. Gently, of course.
Right.
And it can temporarily, slow the heart rate.
Okay.
Now, if the block improves after that massage, it often means the block is above the AV node, a little less worrisome,
But didn't you say earlier that a worse response could actually be a good sign?
Oh, yeah, that's the crazy part.
How does that work?
If the heart rate slows down more and the block gets worse, it suggests the blockage is further down below the AV node. It sounds bad, but it actually means it's less likely to mess with how the ventricles pump.
Okay, so kind of like the bad news is actually good news.
Pretty much. And atropine, that speeds up the heart rate. So if the block improves after atropine, again, it's probably above the AV node. But if it doesn't improve or gets worse, it's more likely below.
So they use these tests along with the EKG to really figure out where that blockage is.
Yeah, it's like detective work.
And that helps them decide about the pacemaker, especially with the 2.1 AV block.
It does. And, you know, Dr. Palazon really stresses that it's not just about the numbers.
Right.
It's about the whole patient, how they feel, their overall health, the whole picture.
It's personalized medicine in action, really.
It is.
You know, and speaking of personalized care, he also has some interesting things to say about vasovagal syncope.
Oh, the classic fainting spell.
Exactly. But it's more than just that, right?
Yeah, it's not always so simple. He says that like over half of these episodes involve significant bradycardia.
Okay.
And sometimes even a systole.
Systole. That sounds scary.
It's a temporary standstill of the heart.
Whoa.
But the thing is, with vasovagal syncope, this systole is usually really brief, and the heart starts back up on its own.
Okay, so like a dramatic pause, but not a full cardiac arrest.
Yeah, good analogy. But he does tell this story about a sommelier, you know, a wine expert who was losing weight and fainting a lot, especially when he was busy.
Really?
Yeah, and he ended up needing a pacemaker, even though vasovagal syncope is usually considered, you know, benign.
Wow, so even something that seems straightforward can have these twists and turns.
Totally. And that's why it's important to look at each patient individually.
Makes sense. So how do we treat vasovagal syncope then? If it's more than just avoid triggers and lie down if you feel faint.
Dr. Palazon's big on reassurance and education.
Huh.
A lot of times just understanding what's happening, knowing it's usually not dangerous, can really help reduce anxiety and symptoms.
So knowledge is power, even when it comes to fainting.
It really is.
This is fascinating stuff. I'm learning a lot.
Me too.
But there's still so much more to unpack about pacemakers.
Yeah, especially about why bicameral is so common.
Yeah, what's the deal with that?
And how do we know who really needs a pacemaker? Especially with those tricky 2.1 AV block cases.
We'll get into all that and more, but first, a quick word from our sponsors. We'll be back soon to continue our deep dive. Okay, we're back, and I'm still reeling from that bicameral pacemaker thing. So widely used, but maybe not the best.
Yeah, it really highlights how complex all this is. So many factors, historical stuff, technology, even money comes into play.
Yeah, for sure. But let's get back to 2.1 AV block for a minute before we go too far down that rabbit hole.
Oh, right, yeah. That's where Dr. Palazon really shines, explaining all that. He's like, it's not enough to just say, oh, it's 2.1 AV block. You got to figure out exactly where the problem is in the heart's wiring to know what to do.
So like finding the exact spot on a map to know how bad the traffic jam is going to be.
Exactly. And where it is makes a huge difference. Like he talks about blocks above the AV node. Those are usually less of a worry.
Okay.
And blocks below the AV node, those can be more serious.
Got it. So how do they figure out where the block is hiding, these cardiologists?
Well, they use a bunch of clues. First, the EKG, a narrow QRS complex. Remember that shows the electrical activity in the ventricles?
Yeah, vaguely.
Well, a narrow one usually means the block is above the AV node. Probably not going to cause too much trouble.
Narrow QRS. Good news. Okay, what about those, what were they called? The massage and the...
Carotid sinus massage.
Right, and atropine. What do those tell us?
Those are like little tests to see how the heart reacts. With the carotid sinus massage, you're kind of like tickling the vagus nerve in the neck.
Sounds weird.
It is, kind of. But it can slow the heart rate down for a bit.
Okay.
And if the block improves after that, it supports the idea that it's above the AV node, less risky.
But hold on, didn't you say a worse response to the massage could also be a good sign? I'm confused.
Yeah, it's counterintuitive, right? If the heart slows down even more and the block gets worse after the massage, it suggests the blockage is further down below the AV node.
Oh.
It seems bad, but it actually means it's less likely to mess with how the ventricles pump together.
So bad news is good news.
In a way, yeah. And atropine, that one speeds up the heart rate. So if the block gets better after atropine, again, probably above the AV node, but if it doesn't get better or gets worse, it points to a blockage below.
So they use all this info, the EKG, the massage, the atropine, to really pinpoint the blockage.
Yeah, and then they can make a good decision about whether a pacemaker is really needed, especially with 2.1 AV block.
It's amazing how much goes into it.
It is, and Dr. Palazon really hammers home this idea that you got to look at the whole person, not just the numbers on a test, their symptoms, their health overall, all of it.
It's all connected.
It is.
And speaking of the whole picture, Dr. Palazon also has some interesting thoughts on vasovagal syncope.
You mean besides just fainting at the sight of blood?
Yeah, is there more to it?
There is. Remember we talked about how it often involves bradycardia?
Uh-huh.
Well, he says sometimes there's even a systole, that temporary heart stands still.
Whoa, really?
But the thing is, with vasovagal syncope, it's usually very brief, and the heart starts back up on its own.
So dramatic, but not deadly.
That's a good way to put it. Though, he did have this patient, a sommelier.
Like the wine expert.
Yeah, him.
Yeah.
And this guy was, losing weight, fainting, especially when things were hectic.
No kidding.
Yeah, and he ended up needing a pacemaker, even though, vasovagal syncope is usually pretty harmless.
Wow. So it can be more serious than we think.
It can. Every patient is different. That's the key takeaway.
That's true with everything, I guess. So how do we approach treating vasovagal syncope then? Is it more than just avoiding triggers?
Well, Dr. Palazon really believes in reassurance and education as first-line treatments.
Interesting.
Often, just understanding what's happening, knowing it's usually benign, can make a huge difference for people.
Makes sense. So, knowledge is the best medicine sometimes.
It can be. And it all ties back into that idea of overdiagnosis and overtreatment we touched on earlier.
Right, right. Seeing something on a test doesn't always mean it's a problem.
Exactly. He has this great example of a patient who had pauses in their heart rhythm during sleep, but were totally fine otherwise.
Yeah.
Makes you wonder if we're jumping the gun sometimes, intervening when we don't need to.
Yeah, that's a good point. It's not just about the numbers, it's about the whole person.
Absolutely. And it brings us right back to the pacemaker debate.
Oh, right. Monocameral versus bicameral.
Yeah. If we're maybe overtreating some bradyarrhythmias, shouldn't we be even more careful about jumping to the most complex pacemaker?
Good point. This whole discussion is really making me think.
It is fascinating, isn't it? And it shows how important research is to figure out the long-term effects of all these treatments.
More knowledge is always better.
For sure. We need good data to make the best choices for patients.
This is definitely an eye-opener. Who knew slow heartbeats could be so complicated?
Right. And we're just scratching the surface here. Dr. Palazon's lecture is packed with insights.
We've learned a lot already, but there's still so much to talk about.
There is. How can we be more informed as patients? What questions should we ask our doctors?
Yeah, that's important. How do we advocate for ourselves in all this?
Those are great questions, and we'll dive into all that right after this.
We're back, and man, there's a lot to think about after that last segment.
It is pretty mind-blowing, isn't it?
Right.
All this complexity packed into something as seemingly simple as a slow heartbeat.
For sure. What really sticks with me is Dr. Palazon's focus on, patient education, being involved in your own healthcare decision.
Oh, absolutely. He even suggests that sometimes the best treatment for things like vasovagal syncope is just, reassurance and understanding what's going on.
I can see that. If you know what's happening, you're less scared.
Right, exactly. Less anxiety, fewer symptoms just from knowing.
That makes sense. And that same idea, being informed, applies to treatment decisions too, right?
For sure. Dr. Palazon wants patients to feel comfortable asking questions, exploring all the options.
Yeah, not just going along with whatever the doctor says.
Right. Like with pacemakers, he's really clear that it shouldn't be an automatic decision. It's a big deal. Got to weigh the pros and cons.
Yeah, and it makes that whole bicameral pacemaker thing even more puzzling.
Oh, totally. If we're not even sure it's the best option, why is it so common?
Makes you think about, the whole medical system, right? What drives these decisions?
It does. And that's why it's so important for patients to be their own advocates, ask those tough questions.
Yeah, don't be afraid to speak up.
Exactly. Get a second opinion if you need to. It's your health.
So for our listeners out there, what are the key takeaways here? If you're dealing with a bradyarrhythmia, thinking about a pacemaker, what should you do?
Okay, first off, learn as much as you can about your condition, the treatments, the risks, everything.
So do your research.
Exactly. Ask your doctor for good resources, websites, anything that can help you understand.
And don't be shy about asking questions during your appointment.
Oh, for sure. Come prepared, write stuff down, bring someone with you if it helps.
2 heads are better than 1, right?
Absolutely. Having an advocate there can make a big difference.
Dr. Palazon also talked about trust. If you don't feel comfortable with your doctor, get a second opinion.
It's your right. You deserve to feel good about the care you're getting.
Absolutely. And remember, there's support out there. Groups, online forums, people going through the same thing.
Don't be afraid to reach out. Connect with others.
This deep dive has been really eye-opening. I mean, who knew slow heartbeats could be this complicated?
It's amazing, isn't it? And Dr. Palazon's lecture really makes you think about the big picture, how we approach healthcare.
It's not just about treating a condition, it's about the whole person.
That's what it's all about. And the more informed we are, the better choices we can make.
Couldn't agree more. Well, that wraps up our exploration of bradyarrhythmias and pacemakers, inspired by the brilliant Dr. Oscar Palazon.
It's been a pleasure diving deep with you.
Thanks for joining us. And to all our listeners out there, stay curious, stay informed, and we'll see you next time on The Deep Dive.